for today's program. I first met Ken Grant when I was a marketing person for a design firm. I don't recall his exact title, but I knew he was in charge of the wine cellar at San Michel Winery, which I thought was super cool. And even cooler, he was the first real Aussie I ever met. The bar was set high. So 20 years later, I get to see Ken almost every week, which is super cool. So just to let you get to know him a little bit better, he is in branding, he's a speaker, he's an author, and also a performer. He's standing far enough away from me that he can't huck anything at me, which is good. After partnering in a branding firm, he started his own firm called Motivated Branding. And in 2014, Ken authored a book. It's called Yoga in a Business Suit, which the coined idea was bit-sized, big ideas. So check that out. Ken is a classically trained pianist. I've had the good fortune of being accompanied by Ken, and he performs around town, and for us, as he did today with our opening song. Thank you, Ken. So all these things combined with his current job as VP of Marketing for Kelly Ross Pharmacy Group, make him the perfect person to moderate this, yes, 6-person panel. So the thing that's the missing link in all this is he is our well-proven and incoming Sergeant at Arms. So this is kind of a test. If he can handle a 6-person panel and be done on time, he gets the job. Come on, Ken.
Yeah. You know, the best thing about 6 people is that I didn't have to manage them. I just had to invite them. So I'm okay. That's Carlos. Oh, come on up. Please, come on up. So I am seriously excited to MC today's conversation. A little backstory. I have, as you just heard, well, you don't know this, but I've been in the pharmacy industry for 10 months this Friday. Oh, this is a tough crowd. And I can't tell you what an eye-opening experience it has been. It has been everything that I did not imagine it would be. It is everything that, and this is why I wanted to bring all my amazing guests up today to talk about this, because I bet you that your frame of reference around pharmacy is probably similar to what mine was. This is no longer about running into the corner drugstore and grabbing some candy and some floss and some toothpaste and maybe some meds. What's going on with pharmacy today is so ridiculously different that that's why I wanted to bring and share what this looks like, the future of pharmacy. The industry is much broader, much deeper, much more complex than I think. I think if somebody like Ryan had told me how complex this industry was, I would not have believed it. It's incredibly innovative, and that's one of the other things that I want to get and share out of our guests today, exactly all the innovations. You're going to hear today also why the state is so incredibly innovative, more innovative, as a matter of fact, than any other state in the country. Come next year, you'll be very, very, very proud of our state. So I wanted to open up with a little video that one of our esteemed guests today basically invented, and it will just sort of, it will allow us to wrap our heads around and open up our minds to the kinds of possibilities that we now see and will be seeing more and more and more of through the pharmacy industry and the work that all these amazing pharmacists are doing.
In-home medication coaching is exactly what it sounds like. We love to go into the patient's home, assess their use of the medication, see what barriers they have to any of the medication use, such as maybe access or education. Maybe they don't understand their meds very well. Especially when they're leaving the hospital, they may have very little understanding and be very confused about their medications. Our ultimate goal really is to have improved patient outcomes. Currently, we get all our referrals through two partnerships that we have in the community right now, and that includes Aging and Disability Services through Medicaid, as well as our partnership with the VM Cardiology Clinic over at Virginia Mason.
Pharmacist is a great pairing for us because that is someone that knows medications, is very able to manage those medications and help people with those issues so that they can make sure that they're set up well at home.
So currently the nursing staff over at the cardiology clinic assesses each patient to see if they're eligible for our program. After that, they'll fax us a referral process, a referral request, which we'll process and then go see the patient.
So by having our team and the pharmacy team identify the patients prior to discharge, we're able to identify those people and work together then to contact them within the first few days they're home, and the pharmacist then gets in their home immediately and really helps them get set up for success, because there's so many barriers and so many issues that can happen. So the communication between us, we've been able to get the pharmacist on our electronic medical record so we could communicate in real time through that to our clinic and the docs and with the pharmacists. It's just been a wonderful partnership.
See, the amazing thing about this process is going into each patient's home and the incredibly different things you see. Some patients you'll go in and often they'll have medications in many different areas. They're storing them in different areas. They have very little knowledge of each medication, and that's definitely something we can provide while we're there. And after we gain all that information about the patient in their home and in their comfort zone, we can take that information, put it all together, and then coordinate with all the other healthcare professionals, like the physicians they're seeing, the nursing staff they're seeing, and to provide those recommendations.
We thought this model of using pharmacists would be a great idea because of their skill level in working with medication and medication reconciliation and compliance, and doing that in the home setting, which we thought would be a really important way to help with that transition of care.
The two most rewarding things about this program are seeing the reduced readmissions that we're having an effect on to the hospitals, as well as seeing the joy in the face of the patient each time they have an understanding of their medications that they didn't have previously.
I didn't believe in the meds. You know, I was like, I don't need to take meds. I'm going to be okay. You know, meds give you this, and meds give you that, or your friends say, I'm not taking meds, you shouldn't either. And, you know, I bought into that for a while, you know, before a pharmacist came into my life and sat down in a humane way and say, Glenda, this is this, and this is what this is going to do for you. You know, and the way they said it, I'm like, I'm a believer, you know. So, and I tried it, and it was like, whoa, that's true. You know, if you take that med, I wasn't taking them right. I wasn't taking them to build up enough in your system. I wasn't consistent. So 1 week I'm having a good week, I take them, and the next week, bad. And the pharmacy had to come and say, that's why.
So there we are. There's the beginning of the future. This does not look like your corner drugstore, us running in and getting toothpaste like I just said before. So without a doubt, I think we've assembled probably the smartest group of futurists and leaders in the pharmacy industry. So without further ado, I would like to introduce everybody that's on here, and then we'll start our questions. So first of all, Professor Peggy Odegaard is the Assistant Dean of the University School of Pharmacy. Peggy is on the front lines of training the future, obviously, of pharmacy, and has a unique insight into how the practice of pharmacy has changed over the past 30 years, whatever, and is particular and is a particular expert in how women are represented in this field. Next to Peggy is Dr. Ryan Ofterbrodt. Ryan is the CEO of the Kelly Ross Pharmacy Group. I shouldn't probably screw that one up. One of the Seattle's most, this is really nerve-wracking. I tell you what, I have to tell you, it's much more nerve-wracking than I thought. I will never do this again, mental note. It's much easier being a sergeant at arms than having to go through this. And I know you all, and you're all my friends, so it's still nerve-wracking. So Ryan runs and is the CEO of Kelly Ross Pharmacy Group, one of Seattle's most established independent pharmacies, and is the brainchild behind exactly what you just saw. In addition, some other things that maybe, if you have not heard, you certainly will be hearing of very soon, like one-step prep and our take-home naloxone kits. I see one head, I know, because you use them. Next to Ryan, not like that, a different kind of use. And next to Ryan is Professor Don Downing, Washington State's leading expert and an advocate on policy changes, wait till you hear what he has to say, that have led to some new opportunities for pharmacy, specifically addressing State Bill 5557 and the novel concept that pharmacists just might get paid to do what they do for a living. You think that's a joke. You'll understand more in a minute. Next to Don is Dr. Amanda Bishop, the practice coordinator for Virginia Mason Medical Center, who is an expert in the collaboration rather than the competition of the future of healthcare and pharmacy. Next to Amanda is Dr. Jenny Bochy. I'm the only one up here without a doctorate and certainly not a professor. Who is the assistant professor at UW School of Pharmacy, and as a live example, I like the fact that you're a live example versus the alternative. A live example of the future pharmacy whose unique perspective on how she's seen the theories and innovation developed in the classroom play out in the real world. And last but certainly not least is Jeff Rochon, Dr. Jeff Rochon, who is the CEO of the Washington State Pharmacy Association. And he has a great influence and perspective on how the entire state's profession of pharmacy and pharmacists are being run. And he is also connected deeply with other associations around this country and how they are collectively then starting to build what the future looks like. So if I may, so this is pretty good, please give them a big welcome. All right, so Peggy, maybe I could start with you. You've been in the front line of training pharmacists for more than 30 years. How has pharmacy education evolved in that time, and what unique skills do pharmacists need today, beyond counting in fives, which if you don't know what that means, it's kind of an inside joke of pharmacies, that make it such a dynamic and changing field? And if we can add on to that, maybe you could even talk and address a little bit about women in this industry.
Thank you, Kent. Is this on okay? Thank you, and thank you to the Seattle Rotary for having all of us here today to share this story. Roles for pharmacists have really shifted tremendously over the last 30 years, and I think if I could sum it up, it would be that our roles have shifted to get closer and closer to the patients that we support. In pharmacies, there are pharmacists working very carefully to help patients manage complex medication regimens. And let's be honest, health is very complex now because we can control so many illnesses we couldn't control years ago. And so pharmacists are sort of reorienting to provide a lot of counseling and education, motivation and inspiration and empowerment to patients to help them manage conditions in their homes, in their lives. And back to the counting by fives, which is really kind of a trigger point for a pharmacist when we hear that, because that's kind of a traditional impression you see in a community pharmacy. But actually, more and more, we have great support systems in pharmacies that are doing that counting, so the pharmacists can really associate themselves and make sure they're well available to the patient. Robotics is taking a lead on a lot of the counting now, counting machines, and then there's support staff in pharmacies, pharmacy technicians and assistants who are really helping support that process of care. With regard to education, it has evolved quite a bit over the last 30 years that I've been in pharmacy education, and in some ways changed and in some ways deepened, but not the topics haven't changed. Just so you all know, pharmacy education now, pharmacists graduate with a 4-year doctorate. So it's a similar level degree as an MD or a DDS or a doctorate of nursing practice type of degree. Most programs require prerequisites before you come in. For our program, it takes about 2.5 to 3 years to get the prerequisites. So over the last several years, our admissions stats would tell us that over 90% of our incoming students have a bachelor's degree. So when pharmacists graduate, they're graduating primarily with 8 years of education, 7 or 8 years of education. It's a very extensive training. And our training really places us in a very unique position, really understanding medications. There are basic science, foundational sciences and therapeutic sciences that we learn so that we understand the pharmacology of the drug, which is kind of the molecular basis of how it's working in the body and what cells it's working at. We understand the chemistry of the drug extensively, which helps us understand how drugs will interact with each other and how drugs interact with the biochemistry of the body and potentially making conditions better or in some cases making conditions worse or causing side effects. We also have oriented a lot of pharmacy education the last 20 years around the very human side of healthcare. that it is tough to manage multiple conditions. For any of you who even have one condition, you know it can be tough with medications to manage even one condition. And consider yourself, the challenges you might have if you had multiple conditions. And pharmacists are well trained in motivational interviewing, in counseling strategies, in providing education and being educators to help all of us learn how to take medications, and similar to what the lady discussed in the video, of really understanding why the medication. And so our training has a very human-oriented side of it to understand how best to support people. And probably one of the big evolutions in training that has happened in the last 20 years is what we call interprofessional education, where we now realize that it's really important for health professionals to learn together. Because if we wait to practice medicine together when we're out of pharmacy school and dental school and medical school and nursing school, it may be too late to fully appreciate how to work well as a team. And so at the University of Washington, we, for example, have 6 health profession schools in our health sciences program. And our students for the last 20 years have been learning together with other health profession students. Our goal is that they really learn to appreciate the roles and responsibilities of different professions, and so that they're very adept at consulting team members, at working as team, at realizing they don't need to know it all, but that someone else on their team can help them out. And our hope, and we're doing actually a lot of research at the University of Washington to follow this, is to see the outcomes in health change because of our students learning together to work well as team members. So that's probably one of the big new things that we have in education for pharmacists and for all health professionals. And I'll just put in a plug, you're in a good area, because the University of Washington is really leading the way in the country in interprofessional education, which is making it a very exciting place for our students to train in that manner. Women. So I am a woman. When I went to pharmacy school back in the early 80s, my class was about 50% women, 50% men. And I came into a profession where when I worked at a more classic chain pharmacy, and when I would go to the counter to help a patient, I would sometimes have patients say, could I please speak to the pharmacist? And I'd be like, I am the pharmacist. And they'd be like, no, I'd like to speak to the pharmacist. And I'd be like, I am the pharmacist. And I want to speak to that person right there. And it would be a male pharmacy technician who was working with me. And so that the profession at that time, it was seen as very male-oriented or male-dominated. And it has shifted quite a bit. Our current enrollment is about 2/3 women, 1/3 men. And just as of 2015 in Washington State, with new people entering the profession and people retiring from the profession, the numbers have now evened out and women are stepping into the lead as far as having a role in this profession. It's a great profession for men or women if you're really interested in all those things I talked about, kind of combining sciences with a human side of attending to making sure your career is focused on people and what they need, and then also kind of working with other people and collaborating. Does that help you out with your question?
That's fantastic.
Yeah, thank you.
I didn't hear any hoop hoop from the ladies. Come on, that's pretty good, yes? Come on. I always thought that was rather impressive. Ryan, so you're a graduate of the School of Pharmacy at the UW, and a very active, and I say that as an understatement, a very active alumni. You're picking a lot of these students that Peggy's pushing out into the world. I'm curious what you see from a new employee standpoint and how they are themselves helping shape the future pharmacy.
Sure. The caliber of the students that are graduating today make me wonder how I ever got through the program myself. They're just absolutely fantastic. They're ready. They're ready to engage in this new model of healthcare as part of the team. And not only are they ready, they're prepared to lead. And I have a couple of great examples. We have a community practice residency program. So we've got, after somebody completes pharmacy school, they'll come and they'll spend a year of intensive training in a postgraduate program. In the last 2 years, we've had absolutely fantastic residents that have graduated from the University of Washington that have both had residency projects that have been recognized nationally as groundbreaking programs. One is our HIV prevention program, our PrEP clinic. And we were actually invited to present this clinic at the CDC last fall as a new model for delivering this type of care. And then you saw another great example of some of the work we're doing in what's called transitions of care, where we're partnering with, in this case, Virginia Mason, to help them reduce their readmission rate for some of their high-risk congestive heart failure patients. And we've got our resident actively involved in this program as well. So they're coming out of school and they're ready to practice at the top of their professional license, which I think is just a great opportunity for us to really drive some change.
All right, so I laughed before about being paid, but I seriously was, I was being rather sarcastic. So I'm going to introduce Don now. From a policy standpoint, the kind of consolidation, the kind of consultation that we hear that's being put into the heads of these new pharmacists, right? It's very different than just as you said before. I want you to explain, please, this state bill that you worked on and how that affects then this future of pharmacy, how people, like what the status quo is today, and then I would like you to share, because I think this is one of the incredible things we're going to hear today, is what's going to happen with this whole payment for work thing.
Yeah. Thank you, Ken. So it's a pleasure to be here. Thanks for inviting all of us here today. To put it in perspective, and watching that video on malaria and such really hit home to me, and listening to Peggy and Ryan talk about the services pharmacists can provide, I'm guessing that almost all of you, when you go to a pharmacy, have very few conversations with pharmacists. I'm guessing that you pick it up and they have you sign a form that says, here, if you don't want to wait for the pharmacist, just sign here and you can go on. Okay, is that a reality for a lot of you? Yeah, it's a reality for me too, and it just ticks me off. So, give you an idea of what we've been doing in this state. We were the first state in the country in 1979 to allow pharmacists to prescribe drugs. You probably weren't aware of that, but we've been doing that for a long time. And in the early 90s, a colleague and I began a special training program to teach pharmacists how to immunize large numbers of people against infectious diseases. And soon we were the largest immunizer of many of these vaccines in the state of Washington. But come along a few years ago, and some of you are old enough to remember when the H1N1 flu virus came into the state, killed a number of people. My background is I do a lot of work in setting up tribal healthcare clinics, and I happen to be working at the Nisqually Tribal Clinic, opening up some services for them. And 2 of the first 6 people who died in the state that year from that H1N1 virus were Nisqually tribal members, young people. The insurance commissioner's office met with all the stakeholders who provide immunizations in the state and the health plans and said, we're going to make sure that there are no barriers to immunizations in Washington state. And I get the press releases from the insurance commissioner's office, and I looked at it and I said, well, as a leader in this effort nationally, I don't remember being invited. In fact, I called the insurance commissioner's office. I said, no, this is only for healthcare providers who provide vaccines. And I said, excuse me, but we're arguably the leading provider of flu vaccines in the state of Washington, and we weren't invited to the table. And they said, well, just have everybody just pay for the vaccine when they go into the pharmacy. I'm thinking a family of 5 at $30 a shot or more. And then they turn in those receipts. Many of those families can't afford it. And it began me thinking that, you know what, I need to continue my effort to make sure that pharmacists are not paid just for selling a product, but actually for the service they provide, and get some of the recognition that's involved in that. We went on and a colleague and I developed emergency contraception for women. You may have heard of that, Plan B. That came out of our school and a local organization, and we promoted pharmacists. We became the largest prescriber of that product when it took a prescription in the state, but many of you you probably don't remember that because the news didn't really talk about that. But in a way to shorten what policy means to you, policy changes, and why I helped create the Senate Bill 5557 last year that finally created pharmacists, medical providers, I want to do kind of a little skit here I've done on occasion. So I'm going to play a 65-year-old male. It's hard, it's a stretch, right? I happen to be a 65-year-old male. Can I have you hold that for me? So think about one of your loved ones in your family, maybe even you, and you have a medicine cabinet at home, or your mother or father does, your grandparents do, and you know what that medicine cabinet looks like, right? It kind of looks like this. By the way, my doctor has today on the stage here, there are a lot of doctors up here, has asked me to bring my medicines from my medicine cabinet in, and oops, I'm spilling it. And look at, there's your family's medicine cabinet on the floor right here. It's a mess. There's cigarettes, inhalers, prescription bottles, maybe a banana peel, something. It's the leading cause of people my age being, avoidable cause of people my age being admitted to a hospital. It's the leading cause for people not to live independently in their homes, because the medicines are mismanaged. You say, well, maybe I'll take these medicines into my doctor. I know there's probably some physicians in the room. But if most patients brought in their big bag of medicines from their cabinet into a doctor, the doctor's gonna say, I got 5 minutes to see you. It's gonna take me an hour to sort this out. Take it to your local pharmacist. So you take it to your local pharmacist, and as great as these people are, they're going to say, I have to fill 400 prescriptions a day with my head down. I cannot spend an hour of my time to take care of this mess. And yet this mess is what's leading people to be hospitalized, and our drug costs. If you're employing people, or if I'm your employee, you know how those costs are going up, and yet we're paying for all these drugs, but we're not managing them. I'll tell you, here's what pharmacists were prior to Senate Bill 5557. This is what I was incentivized to do as a pharmacist. Oh, I can sell you 5 more prescriptions because I'm not being paid to manage them. I'm only paid to sell them. We need access, but we need access to the right drugs. People aren't seeing one doctor, they're seeing 4 and 5. We need to collaborate with everybody on the team, as they've all said, and we need to manage these. Pharmacists are the best trained people to do it. Senate Bill 5557 says if a physician or a nurse practitioner or a PA is paid for providing a clinical care service within our scope of practice here, then it's illegal for a health plan, commercial health plan in Washington State, to deny us payment. So we can spend the time to manage this stuff as the medication expert on the healthcare team. So that's what it's doing, and it's already having a dramatic effect. Clinics are hiring pharmacists like crazy because they need somebody to help with the chronically ill people. The doctors are overwhelmed with these folks. We can be their partner. So that's what that is. We'll take questions more later.
Maybe, yes. I want to know who's going to clean that mess up. It's going to be me. Dang it, it's always me. That's what happens when you don't have a doctorate. Amanda, I'm curious now, from inside of a medical system like Virginia Mason's, this sort of training, thinking from a very creative standpoint, and now the ability to be able to get paid to do what it is that you do. How do you think that's going to shift and reshape the face of pharmacy inside of a medical system?
Absolutely, that's a great question. And for everybody, this is a very real thing. I know Dom put some theatrics to it and brought a lot, but this is a very real thing. This could be a typical patient that I would see in my general internal medicine or my pain clinic, and they bring in 2 shopping bags. Not one. And there's drugs in there that are 5 years old that they were told to stop taking years ago, that they're like, well, I thought I'd save a couple bucks and hold on to it because I might be re-prescribed a couple years from now. And then they take it and then they end up in the hospital. So this is a very real thing for us. And at Virginia Mason, we have had pharmacists practicing as providers in our outpatient ambulatory clinics for over 27 years. So it's definitely not a novel concept for us, and we're very proud of the work that we've done. And just in 2015, our 18 pharmacists in the outpatient clinics had 33,000 face-to-face visits with patients and another 38,000 encounters with patients virtually over the phone or through email and portal messaging. So we are definitely a force on the outpatient side that's highly utilized at Virginia Mason. The downside of that is that we are currently actively involved in 5 of about our 12 outpatient departments. And can you ask, how has this sort of payment and new law shifted our work within our own organization? It's really all been about recognition. So I see 10 patients in a half day or 15 patients in a full day and get paid 80% less for the work that I might have done with the patients. But my physicians, my nurses, the medical assistants I work with, they all recognize the value in it. And now that recognition has spread beyond just the clinical leadership. So our finance and revenue team, our medical staff services team, analytics, they are all now more aware of what the pharmacists are doing and asking what they can do to help us because they see the value in what we give to the patients. And I think you had a latter half about expanding the services within Virginia Mason, and that recognition then dovetails into having more conversations about how do you get a pharmacist into your clinic. And it's been very exciting. We actually are in the process of just kicking off recruitment for a new pharmacist that's specialized in psychiatric care. So as Don may have mentioned, or Peggy and Ryan, after graduation from a pharmacy program, you come out with your doctorate degree, but it's just like your medical doctors. You have a residency program that gives you that intensive 1, 2, sometimes even 3-year training to become specialized in a niche, because there's so much more for us to learn after graduation. And we have those specialists embedded at Virginia Mason, and now we're really pushing forward to better close the gap in care, especially with behavioral health within our state, which I'm sure many of you are aware of. So the recognitions led into that, and now we have 2 more departments within primary care that have approached our pharmacy leadership asking, how do I get my own personal pharmacist? What do I need to do? What paperwork do we need to get in? How do we get them to the table to help me help my patients as well? So it's been very exciting, and we're going to continue to move forward.
That's awesome. All right, Jenny, you ready? So here is the future of pharmacy right in front of us. You know that, now the rest of us know that. I'm curious how you and your cohorts right now are shaping this future. I mean, you're literally connected to one of the more recent, you're also recent graduates, but you're also an associate professor. You've also got a foot in mainstream pharmacy. But you and your friends are like, oh, your heads are exploding. So what are you all working on?
Sure, and I have to say being given the title of Future of Pharmacy is a lot of pressure, but I think that my colleagues, the new practitioners and the new pharmacists, are able to fulfill that. We are practicing patient care providers, and we're doing it as members of patients' healthcare teams. And the thing that I love about pharmacy is that we're doing it in every setting imaginable. Pharmacists are taking care of patients in the hospital. They're taking care of patients in physician offices or primary care offices. We're taking care of patients in the community setting. We're going into patients' homes, and we'll even go into workplaces. So we really are where people need us. We are already there, or we can be there. I myself practice in a housing and urban development funded housing organization. And so I go into these buildings and help adults 65 and older figure out their medications so they can age in place. We make sure they're not experiencing any side effects, or that their medications might cause them to fall. So keeping people in their homes for as long as possible as they age. And you've heard a lot about the different services and opportunities that pharmacists are providing, and I thought I'd share just a few more. One of the big issues that my generation, and really the whole profession as a whole, is working on is adherence. what motivates a person to take or not take their medications is highly complex, and it's very dynamic. It changes. It can change very quickly. And we, as pharmacists, want to be the healthcare professional stepping up and saying, we can help you address any issues that might be preventing you from taking your medications. Additionally, point-of-care testing. A great example of this is flu. Flu hits you really fast. So imagine you're sitting at your desk and all of a sudden you start feeling really bad, but you're not sure if you can get into your doctors, you don't want to go to an urgent care center. Well, in some pharmacies across the country, you can walk in without an appointment, be assessed by the pharmacist, and if appropriate, they'll administer a point-of-care screening test for influenza. And if you screen positive, you can leave the pharmacy that day with an antiviral. If you don't screen positive or it's not influenza, the pharmacist is going to make recommendations for medications that can help you manage your symptoms, so it can make you feel better, whether it's relieving your fever or relieving muscle aches. So across the country, and here in the state of Washington especially, the new pharmacists are ready and willing to be patient care providers and already are.
Love it. Jeff, how are you, as the CEO of the States Association, how are you seeing pharmacy and pharmacists adapting to the ever-changing healthcare?
Well, Ken, thank you for the question, and I just want to say thank you for allowing me the opportunity to speak to you today. I have the best job in the world. I get to work with these folks to help other people. I mean, our job is about caring for folks, and in this ever-changing world, it's interesting because, as Don referenced before he spilled all of his stuff all over the floor, we had laws passed in 1979 that allowed pharmacists to integrate into teams. And so a lot of this change that we're talking about now has been occurring over the last 30 years. And really what we have is pharmacists integrated into all these practice settings. We talk about the community setting where most people believe pharmacists work, but we have pharmacists in clinics and nursing homes and hospitals in every area, not just dispensing meds, but working in the teams. And so that change has already occurred. And it's been over relationship development and trust development for decades. The main issue that we've had is perception. And that perception is that pharmacists count by fives and work at a chain drug store, and they don't get a chance to talk to me because they're understaffed and there's a long line, and that's the perception. The real value to what I get to do is, I was even trained back when I had hair to do this stuff. I couldn't do it now, but I was trained not to dispense medications, but to work in these teams, to educate patients. Education is the fundamental core of what pharmacy is about, educating about the complexity of the disease states and how to appropriately utilize these medications to stay healthy, or talking with our colleagues about the ones that should be prescribed. And so I think a lot of that change has been over a course of a decade to 2 decades to 3. The big fundamental shift now is, how do we, in a changing healthcare system with Affordable Care Act changes and the like, how do we capitalize on this well-trained member of the healthcare system that is not patient accessible? The payment for the services they provide has been ignored by the insurance companies. And so what this legislation that Don referred to, that we've all worked really hard on for decades, by the way, and finally had some success, really just allows patients to have greater access to the care that pharmacists provide by including them in the preferred networks of providers that your insurance company restricts you to. And so you're going to start seeing over the course of the next couple of years that is an option, and more accessible, easier, and highly specialized attention provided to you by pharmacists in the community, in the clinic, in the hospital. And that team approach and the specialties of that are fundamental to addressing our problems with chronic disease or preventable diseases that plague us all. So I see our members now shifting from the kind of frustration of, I've been trained to do something that I'm not allowed to do, to, wow, I have to learn a new process. I have to learn a new structure. We have to change workflow. We have to change those. And that change is hard and difficult. But we have amazing people like Jenny and Amanda and Ryan out on the front lines that are educating patients and talking with their docs in the community and their nurses in the community to move forward and help you all stay healthier.
Thank you. We have time for one question or no questions? That's it. Thank you so much. Please thank our guests today.
Week 3 in the hospital following my cardiac arrest, my cardiologist told me of his plan to implant an internal defibrillator into my chest. The device would shock my heart back into normal rhythm if needed. In my stripy hospital pajamas with tubes and monitors everywhere, I puffed up my posture and said, "I'd like to talk about my options." He looked at me gently. He said, "Dying. We don't recommend that one." Needless to say, I agreed with his plan. And it only took the device going off once a few months later for me to fully buy into the idea. Without financial backing and in spite of skepticism, 3 scientists spent 11 years researching the idea that became the internal cardiac defibrillator. An idea that to date has saved my life 3 times. My defibrillator and my antiarrhythmic drugs every day remind me of the passion, investment, and perseverance that drive medical innovation. For how much we humans dislike being thrown off course, our resilience is quite extraordinary. See you next week.